So good morning, everybody. Thank you for having me and for extending an invitation. My name is Andrea Rivera-Sepulveda. I am a pediatric emergency medicine physician over at Nemours Children's Health in Orlando, Florida. I'm also associate professor of pediatrics, director of research for the graduate medical education. And I wanted to talk to you about precision medicine today. So the title of my talk was Pediatric Precision Emergency Medicine, Bridging the Gap between Bronchiolitis and Early Childhood Asthma. So some challenges in pediatric emergency medicine. So pediatric emergency medicine, unlike other types of fields, it's very touch and go. You only have very limited time in a very high-paced, high-stress, high quantity patient volume setting. So oftentimes we may deal with situations where patients may present in very clinical ambiguous situations. So certainly because of that, some of the decisions that we make in the emergency department around interventions can certainly vary significantly amongst ourselves between providers and also between institutions. So my work specifically addresses how clinical decision-making impacts patient outcomes and how we can de-risk that ambiguity using prediction tools and precision medicine. So when I talk about precision medicine itself, most of the time, it will bring to you possibly pharmacogenetics or genetic information and making, patient decisions regarding their genetic makeup. But in reality, precision medicine really stands for doing the right thing for the patient at the right time. So it's essentially personalized or tailored care. And it not only focuses on, the genetic makeup of the patient and pharmacogenetics, but it transcends all of that and involves other tools that we do have at our disposal, such as the electronic medical record. So for example, when we have patients that come into the emergency department with a tracheitis, and we look back into that patient's medical history, and we see that that patient has had multiple episodes of tracheitis by Pseudomonas, for example, and that Pseudomonas that they have had is resistant or susceptible to ciprofloxacin. And we decide to go ahead and then treat that current tracheitis with that same medication. That is precision medicine in itself, in a nutshell, because we are making decisions that are tailored to our patient based on their care needs. And that is just an example. For the most part, when I talk about precision medicine, or my field of interest is essentially respiratory diseases in our patient population. So I want to talk to you a little bit about what bronchiolitis is. So bronchiolitis is an infection of the smallest of the airways, essentially characterized by the American Academy of Pediatrics as a lower respiratory tract infection that may be represented by wheezing, crackles, increased work or breathing, and or hypoxia. It's very broad, very somewhat vague, and it certainly encompasses a very broad distribution of age ranges between 1 month and 24 months. But it is the number one of the most common causes of emergency department visits, and certainly of the most common causes for hospitalization in our current healthcare resources utilization across the United States. So much so that oftentimes about 80% of children before 12 months of age will develop a bronchiolitis episode. So 1 in about 9 will be affected. Sorry, 9 in 12 will be affected. And by 24 months, virtually everybody will have had some type of insult to that lower respiratory tract infection, possibly caused by one of the most common etiologic agents, that is respiratory syncytial virus, or RSV. So in a nutshell, bronchiolitis is just everywhere, affects virtually most of our patient population, and it causes a significant burden in the resource utilization of our emergency departments, and healthcare use, as well as possible morbidities and mortality in our patient population. So why am I utilizing this as my model for heterogeneous treatment response, you may ask? Well, based on the American Academy of Pediatrics clinical practice guideline publication back in 2006, the recommendation for management of bronchiolitis said, well, let's just go ahead and give a trial of a bronchodilator, it's specifically speaking about albuterol, and see how that patient does. Some children do tend to respond, some children tend to not respond. So at that point in time, it was thought that let's go ahead and try it. There's no downside in try it. Now, when they updated those clinical guidelines in 2014, they said we no longer support the trial and we recommend not to do anything. In fact, the sole management for bronchiolitis currently based on the American Academy of Pediatrics guidelines is just plain supportive care. And the reason for that is because they had documented that giving a single trial of albuterol to see if that patient would or would not respond can go upwards to $40 million a year across the United States. With a 50-50 chance of responding to not responding. Hence the need for utilizing, or the opportunity for utilizing, precision medicine in this patient population. So currently we have a lot of variability in the use of bronchodilators, specifically albuterol, in that patient population. Over the past 10 years, we have also started utilizing a new respiratory support mode called high flow nasal cannula to try to circumvent that therapeutic decision and steer clear from that bronchodilator to more of respiratory support. And certainly how that affects our current disposition decisions. Overall, my belief is that certainly clinical practice guidelines, although they are a guide, they are a one size may not fit all management of that patient population, and certainly fails to address heterogeneity. So we know anecdotally and in literature that some patient population does benefit, but we don't clearly have a tool that has been able to address or identify who that patient population is. So my vision towards the use of precision emergency medicine in that pediatric respiratory illness is to bridge that gap between our real-time clinical decision making of utilizing, trial medicine to utilizing more precision-based tools to identify the responsive population and hence improve patient outcomes. And there's multiple ways that I envision doing this work. Obviously, mixed methods, multi-omic profiling, and the integration of clinical and biological data. Now, I would like to talk to you a little bit about how I started addressing this problem. In 2022, through my work on the PEDS network on a K-12, I aim to develop a clinical prediction rule for bronchodilator responsiveness and develop a real-time clinical prediction rule that would identify those infants less than 2 years of age with bronchiolitis who were likely to benefit from bronchodilators. And then at that point in time, I went ahead and designed and implemented a single-center, double-blind, randomized placebo-controlled trial of a single albuterol dose to evaluate and integrate clinical data, physical data, and genetics to make informed decisions about patient care. And why is that important is because although we know that bronchiolitis is very, very common in our patient population, literature has shown that children with either multiple episodes of bronchiolitis or severe bronchiolitis will go on to develop asthma. Before, we used to think that asthma could not be diagnosed before 6 years of age. That has now started to slowly, gradually change and decrease that threshold of age diagnoses. And we're currently doing an asthma diagnostics earlier, from the age of 2 to the age of 3. Now, the question would be the philosophical question about the chicken or the egg. Do you go on to develop bronchiolitis because it's just a natural progression to asthma? Or does bronchiolitis in itself cause asthma. We just don't know the answer to that. What we do know is that by following very strictly clinical practice guidelines that say do nothing and just provide supportive care, we may be failing to identify that subgroup, that patient population who might benefit from that treatment. And essentially, we're just, for the lack of a better word, is just withholding care for those who will or who might benefit, and might be debuting, early childhood asthma. So that is why this is important. And obviously, it also optimizes treatment pathways. If that patient is, in fact, developing early childhood asthma, then that patient could be put earlier and more appropriately into the care pathway that they require, which will probably involve steroids and more close observation and follow-up and so forth. So some of the mechanistic insights that are associated with therapeutic heterogeneity, one of the hypotheses, like I mentioned before, is that a subset of infants with bronchiolitis will show some distinct asthma type endotype. And then one of the ways that we're trying to identify that is by genome-wide or GWAS assessment of DNA methylation profiling, genotyping the asthma risk-related SNPs, which have been very well documented, and correlate that with bronchodilatory response utilizing a respiratory scoring system or assessment tool. So based on our preliminary data from July 2022 to December 2023, we had at that point in time enrolled 82 participants. We identified that over a little bit of 1 in 4 that were treated with albuterol had 2 or more point discrimination in terms of improvement in their respiratory score, identifying a high responder group. What we did find, though, is that after, collecting all the information and data about their history and physical exam, both before and after treatment, that information did not reliably predict bronchodilator response. So then we dove into what their genetic makeup shows. And the GWAS identified some candidate coding and non-coding SNPs that were linked to bronchodilator response, which supports further research in its genetic basis, and some pilot data supporting why this is important. You might ask, well, we don't have time in the emergency department to just sit around and wait for that genetic information to turn back around. You see that patient, you will probably treat it, have, face-to-face time with them for about 60, 90 minutes, then you go ahead and you make a disposition. But in reality, there are some real-time tools that we have at our disposals where we can move away from microarray platforms that have about a 2-week turnaround time for that genetic information to rapid genotyping platforms for potential real-time clinical use. So for example, if we were to identify a SNP that is highly correlated with bronchodilator response, that SNP can be identified at bedside with a rapid test, much so like we do with a RSV or even a COVID rapid test. And that can be done easily and feasibly at a CLIA certified lab for about 45 minutes. So how does this work in terms of expanding the research pipeline? What are the fundable initiatives that are aligned with the precision medicine work? So I've obviously developed some foundational knowledge and information regarding bronchodilator response to develop that precision clinical tool development, which the randomized clinical trial is still ongoing and currently holding strong at 144 patients. And we foresee, epidemiologically speaking, that we will have a very strong respiratory season. So it's not that I want my children or my patients to develop bronchiolitis, but if they were to develop bronchiolitis, I just want them to come to Nemours. And hopefully I will be able to enroll them in the study. Other ideas revolving this relationship between early childhood asthma and bronchiolitis revolve around genotype epidemiology of the respiratory syncytial virus, or RSV, which is one of the top most common etiologic agents. And this is important because as of 18 months ago, we now have FDA-approved vaccines that have started to be administered to mothers while pregnant so that they can provide passive immunity to children in utero prior to birth, and those be protective within the first 6 months of age. And we also have monoclonal antibodies that are being administered classically before this through Nemours within those first 6 months of age and each respiratory seasons before the patient turns 2, that should also protect against severity for RSV. We do know with the new administration, vaccinations makeup or vaccination practice is certainly changing. So we need to see how that is going to unfold. But the idea when we came up with the genomic epidemiology of RSV is that if you do introduce a new vaccination, there's a possibility that there could be a shift in the strand because there are different RSV strands where there could be, protection towards bronchodilator non-responsive RSV bronchiolitis to a shift towards bronchodilator responsive RSV bronchiolitis. And that's one of those questions that we have floating in our mind, and hopefully we'll be able to dive into shortly. And then the other thing is about the omics related to lung stress associated with high flow nasal cannula therapy. So a recent study that's currently under revision for publication show that patients with severe bronchiolitis who go on, or moderate to severe bronchiolitis who go on to high flow nasal cannula therapy end up developing asthma. So we are not quite sure whether this high flow nasal cannula is related to a marker of severity or if there is some type of indication for lung stress, acute lung injury associated with that patient population that we could, potentially dive further into. Obviously, to do all of this work, I have leveraged different infrastructure opportunities, such as the PeaceNet Scholar K-12 and the Nemours Biobank for the integration of the clinical and biospecimen data, and also collaborating with genomics core and infectious disease experts. And then in terms of my vision forward for this work is obviously develop a data-driven risk stratification tool in the ED, integrate the omic profiling into hopefully routine acute care, provide improved information to improve guideline concordance with personalized interventions, and contribute to national guidelines in pediatric emergency medicine innovation. So this is just a gentle reminder or a call to collaborate and innovate about the data science, the genomics and epigenomics behind respiratory diseases in this patient population, any clinical trial associated with pediatric emergency medicine, and anything related to, resident or fellow mentorship related on bronchiolitis projects. I would like to make a quick acknowledgement to my mentors and collaborators, research coordinators, the PeaceNet Scholarship Program, and obviously Nemours. And I want to extend a big thank you for allowing me to share in this work with you.